Take a moment and welcome everyone to our second webinar for the AHPBA clinical trial webinar series. For those who were not at the last session, I just want to give a little introduction about sort of what is the purpose of this webinar series, and what we had come up with in the clinical trials committee is to really put on a course and a forum for those who are interested in clinical trials and learning how to proceed clinical trials, and really put them in touch with speakers that are really like experienced, obviously, and then move forward with it with a final session that we will have at the upcoming annual meeting. So look forward to really having that final session. Our last session was about really how do you select a clinical trial question and how do you go about picking a design. And so that was for the introduction. That was really, really successful. So I really appreciate everyone who logged on. And today we'll have the honor of like really 4 phenomenal speakers, and we will discuss clinical endpoints for various different types of trials, and then lead on a discussion to discuss correlatives. Just as a quick reminder is we want this to be interactive. So the speakers will have, some set of slides and talk about it, and then also have a Q&A session after each speaker. And then lastly, there are going to be questions that are going to go out after each webinar series. For those who listen to it either live or on the video, that's totally fine, and you want to get credit, we will give a certificate once you have a passing score on the final exam. So without further ado, I'm going to pass this on to Guillaume Martel, who will be doing the introduction to our first set of speakers.
Hi folks, Guillaume Martel from the University of Ottawa. So let me introduce our first speaker, Professor Mark Besselink, who is a professor of pancreatic and hepatobiliary surgery at Amsterdam University Medical Centers, University of Amsterdam in the Netherlands. He co-founded the Dutch Pancreatic Study Group in 2002 and the Dutch Pancreatic Cancer Group in 2012, as well as the European Consortium on Minimally Invasive Pancreatic Surgery in 2016. He was trained as a surgeon in Utrecht, Amsterdam, and Southampton, and he's designed and coordinated multiple randomized controlled trials in acute pancreatitis and pancreatic cancer. He's the current chair of the scientific committee of the Dutch Pancreatic Cancer Group and Dutch Pancreatic Cancer Audit, Dutch Pancreas Biobank. And he is the 2021-2022 president-elect of the AHPBA and chairman of the innovation subcommittee of the AHPBA. So Mark, take it away, please.
Thank you very much, Guillaume. You seeing my slides? Yeah, cool. So first of all, I want to thank the AHPBA for inviting me. Great honor. Even the timing is perfect. It's 11 o'clock in the evening here. I just had a lovely dinner with the PREOPENG 2 trial group. So I hope I don't fall asleep during this talk. So I'll breeze through my slides a bit quickly because my main aim is to have a discussion with you at the end. So I'm just going to show you a few examples of what we did in the Netherlands. So these are my disclosures. Basically, all the trials were funded by all of the companies. So I guess that then splits it. So first, a little new data. You may find this exciting. So we did a systematic review of all randomized trials in surgery, published in PubMed. Okay, so all fields of surgery. So 2 decades of surgical trials. So the top 10, go straight for the top 10 in countries in the absolute volume of surgical trials. So USA is now passed by China. So China is now in 2019. So these were 3 single years in PubMed. In absolute volume, China is leading now over the US, and the Netherlands, tiny country, 17 million inhabitants, is number 4. And then, of course, being from a tiny country, we also calculated the relative volume, so the number of trials per million inhabitants. And then here, the Netherlands is slightly off, but we are actually now second, and Finland is leading. And we also looked at the quality of randomized trials, defined as low risk of bias. And then here combined, the Netherlands was second and USA was 7th. So combining the volume and the low risk of bias, I think it's safe to say that we are world champions in surgical randomized trials in our tiny little country. So why is that? I'll get into that in a minute. So first, I want to give you just 3 terms, very briefly, write them down, look them up later. You may have heard of 3 new designs that may help you guys in doing surgical randomized trials. So here they come. Number 1, registry-based trial. You may have heard of the wonderful Nesquik-based trial with antibiotics in Whipple surgery, led by the group from MSK. Use a registry to collect your data. The only thing you add is the randomization of the patients. So all the data come from the registry. So in the Netherlands, we're doing a trial with drain, no drain in distals, but you already did a great trial on this in Nesquip. That's one. Number two is trials within cohorts, so twigs. So you have a registry, prospective cohort, and what you do, you ask all patients to enter the cohort and sign consent. And you tell the patient, if there's a new treatment, would you like to be informed? You may get new treatment in a trial. So usually patients agree. So then what you do, you identify patients within the ongoing cohort, a small group, who are then randomized. The patients who are randomized to the treatment get a phone call. Listen, do you want this new treatment? But the control group, those who are randomized to the control group, they never know. They stay in the cohort. So you don't have the problem of people refusing to be randomized. So that's two. And finally is three, is a step wedge trial. So where you randomize entire clusters or entire hospitals. The only thing you do, actually, you randomize once before the entire study starts, and you randomize the sequence at which clusters, so say a hospital, is receiving an intervention. And at every time point, say at 2 or 3 or 4 months, a new hospital is added. So we did this with a trial, PACAP1 trial, where we implemented the best practices for pancreatic cancer in the Netherlands. And stepped wedge, we implemented it in all Dutch centers. So we did a nationwide trial. And we did a second trial, the PORS trial, halving the mortality after all of pancreas surgery in the Netherlands by implementing the best practice of identifying and treating complications, the PORS trial that was published last month in Lancet. So looking at these 3 new trials, we saw that they are very new and upcoming. So 93% of all those we found in the last 30 years were published in the last 6. Okay, so in 6 of the 30 years, most of these trials were published. And again, most from Europe, and then within Europe, the most from the Netherlands. The USA and Canada did 5 of these, New Zealand 2, and half of them are from gastrointestinal surgery. So some new trial ideas. So getting back to the Netherlands. So what is so special? Well, one, we have a very strong collaboration between centers. And because of that, we can do a nationwide coverage. So for instance, we're running now a randomized trial on robotic Whipple. The only way in the entire country you can get a robot Whipple is to participate in the trial, because all the centers join, and you can't get this procedure outside the trial, which clearly I understand will never happen in the USA. We have a system of fully clinical PhD students. They have never seen the inside of a lab. My PhD students literally don't even know where the lab is. So they only do clinical trials for 3 years and nothing else. We love evidence-based medicine, randomized trials. We have a health reimbursement system that doesn't pay for procedures. So whether I do 1 Whipple per year or 1,000, I get the exact same salary. And that helps. And of course, if you do, like for pancreatitis, for instance, you do a trial endoscopy versus surgery, there is no financial incentive. So clearly that helps. 5 patients are referred to a unit, so not to a surgeon. So within a unit, you would say, okay, you or you two do, for instance, all the minimally invasive cases, we do all the open cases. That doesn't matter. So then that really helps with getting high quality and doing studies. And then finally, we have nationwide registries, which are mandatory, so you can use them for doing studies. So, and we're great friends. Here's just a group of all the Dutch AHPBA surgeons and PhD students in the Geneva meeting 2018 on the Dutch evening. So if you really want to find out, come to the Netherlands. So this is C. Many of you may know him. He spent an entire month with us, and I think he can tell you 1,000 great stories of stupid things we do in the Netherlands and how the system works. So go out and I'll see if you run into him. So a little bit pancreas. I heard you had some stuff about pancreas before, but of course I'm a pancreas guy, so bear with me for a few slides. This is the pancreatitis study group. So we formed this more than a decade ago with surgeons, gastroenterologists, radiologists, and we did trials. And the next slide I'm going to show you, I'm extremely proud of, is definitely not my work, it's the work of this team. This is the slide. So these are the first 10 trials we did within this group. So this is a group of 60% surgeons, 30% gastroenterologists, and radiologists. All the trials, without exception, were published in Lancet, New England, and JAMA. There was nothing special about these trials. Vast majority of them basically showed that stuff we were all doing didn't work. Basically, you need to do less. So basically, we're negative trials. I just want to show you this, that we're doing very basic trials, answering questions that you face every day. Do I start tube feeding now or tomorrow? Do I do an ERCP now or wait for 2 days? all these simple stuff, answering these questions can really help patients and can give you great research. So we tried to copy that with the Dutch Pancreatic Cancer Group. These are the trials running now in the Dutch Pancreatic Cancer Group. Clearly more difficult to get a straight row of these top 3 journals, but you see we're doing pretty fine. And I just put some flags down here so you see that also we're now working together with other countries in Europe. So we did a bunch of oncology trials. I won't bother you with it. Just tell you one trial, that this is the PREOPANC1 trial we're quite proud of, where we tripled the 5-year survival in pancreatic cancer. Still horrible, but still we tripled it with neoadjuvant chemoradiotherapy. It was the first trial with neoadjuvant chemoradiotherapy in pancreatic cancer that was completed. So there are more PREOPANC trials, but for the sake of time, I'll skip that. So my main point for today is this. So perioperative techniques and trials. So this is not about research only. It is about finding a way to bring a new technique to your center and in the process doing research. So I think these 2 things can very well be combined. So this is, for instance, a PREOPANC4 study. I think you know all of these guys who are leaders in the field of locally advanced pancreatic cancer surgery. And what we're doing with that, we formed a training program, a nationwide training program, meaning like we're doing now, webinars, surgical webinars. We go there, they come to us for proctoring, and we have a nationwide expert panel. And in doing that, we're trying to double the rate of patients getting a resection for locally advanced pancreatic cancer by just better patient selection, better use of chemo, etc. So this is a prospective study, but it's actually basically improving the quality of our care. And the endpoint here is survival, basically the same survival as you would get for borderline resectable pancreatic cancer, but with the same morbidity and mortality. So very simple, improving care and doing research at the same time. So we copied this for a few strategies for minimally invasive pancreatic surgery. This is distal pancreatectomy. We did a nationwide training program. Basically, the deal we gave the surgeons was, wait, we'll train you for free in this technique. We'll take care of everything. The only thing we ask from you thereafter is you join the randomized trial. So we trained them immediately. The number of minimally invasive distals increased by 700%. Conversion rate went down from 38 to 8%, 0 mortality. And here you see our trainer at the time, Mo Abu Hilal, in several Dutch centers. Immediately thereafter, the randomized trial, again showing here minimally invasive, short hospital stay, and all the components of this endpoint also significantly beneficial. And this was in surgeons just trained in this technique. We repeated the thing, exactly the same for laparoscopic Whipple. Outcome in the first 4 centers was pretty good. With this volume, 10% conversion, 3.5% mortality, very same thing. The only thing in the randomized trial, when the volume dropped 50%, so very important lesson, volume go down, outcomes worsen. So here the outcomes were not good for laparoscopic Whipple, and we stopped as a country. So big tip, if you do a surgical trial, consider to randomize 2 to 1. So the new intervention you do twice as often. So we did the 3rd training program for robotic Whipple, bringing in the great friends from Pittsburgh. Here you say Herb with me on my 3rd robotic Whipple in the Netherlands. So at the moment, 1 in 4 of all Whipples nationwide in the Netherlands is being done robotically. Here we trained only the Dutch centers that could do 50 Whipples per year minimum, right? So we didn't train the 6 lower volume centers. And so we're working with this team. So I think this is really amazing. And Melissa Hawk, Amer Suraigat, and Herb Say came to the Netherlands for full weeks. And in these weeks, we drove them to several hospitals so they would do 3, 4 to 5 robotic Whipples in 1 week. This was an amazing experience. So this is now copied into a randomized trial again, this time a European-wide, the Diploma 2 trial, where we look, and here are now a few things about endpoints. So we're going to look at the comprehensive complication index, but that is non-inferiority. So the main thing we want to show is not now, because we're still relatively early in the learning curve. We just want to show it's not worse. Okay, so non-inferiority, just show it's not worse. But secondly, with a second sample size calculation, if we get the chance, we want to show that it's superior for time to functional recovery. So 2 sample size calculations, the main one for basically safety, and the second one, if it's safe, the second one, so we get a chance at showing some superiority. So this is a thing you can think of. Outcomes, clearly all complications, oncologic outcomes. What I think is really interesting to use this Fitbit, so all our patients wear this within the trial. up to 3 months after surgery, so you can really have a readout what they're doing. One tip, don't show them how much they walk, because actually there's one randomized trial where they had a Fitbit and the patient with the Fitbit walked less because they thought they reached the target and stopped walking and start reading a newspaper. Second big tip. So combined superiorities, and then again, I told you 2-to-1 randomization, and then we are blinding the patients for 5 days. We're blinding them. They all think they had robot 100%. It's funny to see even the open ones go home 2 days earlier because they think they had a robot operation. And then clearly be specific about the volume you require if you do a surgical technique. So the trial is running, and we have now also started the training program for robot Whipple. Basically what we did with the Pittsburgh team in the Netherlands, we're now rolling out in Europe in high volume centers. So finally, in my 12th minute, so randomized trials in HPB surgery are feasible, clearly if you have the correct setting. Start with a group of friends, be very pragmatic about it, work together on the protocol, spend a lot of time on the protocol, and in great detail, authorship details. I've seen so many studies in other groups go wrong because people fight over authorship stuff. Put that in the protocol on day one. And then for surgical technique, it's great to combine innovation and research to move things forward, and then use the existing registries and databases whenever possible. So greetings from the Netherlands. This is the team photo at AHPBA, all the Dutch PhD students and surgeons at the Netherlands Club in New York. We had a great time, and all the PhD students. So thank you very much.
Okay, thank you so much. That's highly impressive. Let me, I think we have one question in the chat. Let me ask the first question. Can you tell us a little bit about how you go about choosing endpoints for these trials? I think we want to focus on endpoints a little bit. So, you know, between some of these studies where we have options in terms of morbidity for MIS surgery versus open versus more functional outcomes, what's the process like, and how do you go about choosing those?
Yeah, so there's a great editorial in New England Journal of Medicine, which is called the sample size Samba. And basically what you do is, people will tell you different things, but basically what you do, you calculate back. So you say, well, yeah, what's what it is, right? So what is feasible? Clearly everyone wants to look at mortality, but that's often not feasible, often also not necessary. So I'll give you one example. So in the Diploma 1 trial, which has completed, and we randomized 380 patients in 35 centers in 17 countries across Europe. The only thing we wanted to show is that minimally invasive distal pancreatectomy for cancer was safe. So what could you do? We can never show survival. So what we did was a radicality. So non-inferiority for an R0 resection. So you can debate that forever, because is that really what is going to, so the thing is what you're trying to prove. So for instance, where we did a study for pain treatment after open HPB surgery, we wanted to introduce the pre-peritoneal wound catheters. So again, we said, okay, let's just show non-inferiority for pain control. It can be slightly worse, but in fact, it was a bit better. So usually very pragmatic, and usually it's in minimally invasive, it's time to recovery. And usually in the, for instance, the pancreatitis trial is just a composite of multi-organ failure, mortality, and reintervention. So, but most important point, be very pragmatic about it and choose something between the ideal situation and what works.
Outstanding. I think we have a question from Dr. Michael in the chat. Can you comment on the funding model for the Dutch groups and doing these trials, and perhaps a relationship with industry as well?
Yeah, thank you. Yeah, that's a big problem. So, for instance, for the last trial we're starting now with pancreatitis, with omega-3 fatty acids, took me 9 years to get that funded. 9 years. And the industry wanted to fund it, but wanted to have a second product of theirs, for instance, as a placebo group, as the control group, which product we don't use in practice. We said, no, we don't want that. So getting increasingly difficult. The industry funding in that systematic review we are doing is down 20% in a decade. So that's a big problem. For MIS, we can still get funding from industry. For pancreatic cancer, what we did, we set up something called Delta Plan Pancreatic Cancer in the Netherlands, where we're getting private funding ourselves. But then requires a whole organization. So funding is difficult, although I must say that I think, as was done by Nesquip, and hi Henry, I see you there, the registry-based trial, I think that for surgery is definitely the way forward, because you can do trials with a relatively low budget. So I think that is, for, especially for surgical technique, definitely a potential way forward.
I think we have maybe 3 more minutes. If there are questions, feel free to go ahead and ask or write them in the chat. I have another quick question. Do you have a formal process for when you choose an endpoint for defining your minimal clinically important differences? Do you use a formal process like Delphi's or these sorts of consensus conferences, or how do you go about doing that?
Yeah, that's a great question. So we've tried that, formal Delphi, but I don't think so. So usually you are the group who's designing the trial, say maybe 5 to 10 people. And then, for instance, we completed a study about what is the added value of adding an MRI to a patient with colorectal liver metastasis, which are resectable. You want to take to the OR based on the CT. So how many MRIs should you do to change the actual clinical management? And it's always going to be somewhere between 7.5% and 15%. For this one, I think we decided 10%. We didn't know. And what I find always a good trick is to go and ask the people who will review your paper. Okay. So what we did for several of these studies, for instance, you can look it up in the pancreatitis studies, we did a so-called expert survey. And an expert is defined as someone who publishes on the topic. Most would consider that an expert, who knows? So we would ask them questions, and out of that survey would then be taken into account when deciding the trial. Second thing about that trial, we had a big debate on whether we should use contrast, gadolinium. So there was a debate, do you need it, do you don't need it? We called 2 reviewers and say, what would you, if you would review this study and we wouldn't have used contrast, what would you do? And both said, we would throw it in the bin, reject, don't even read the abstract. So that decision was quickly made, added. So it was added to the final trial protocol, and now our study is completed.
I think we have time for one last question. So from Catherine Davis, can you discuss a bit more about collaboration and creating your study groups? How have you found the best way to get started with this?
Yeah, so 2 things: 1, friends, and 2, a critical mass. So typically you need a chairperson, someone who's been doing this for so long. People know that he or she will not run away with your paper. Okay, so trustworthy person. And then you gather so many friends around that person that the others think, they're all there now. Now I can't miss out. I need to be there. And then you put something very simple on paper, very pragmatic, simple structure, make a website and a logo and go. Website and logo, people think it's stupid, but once you have a website and a logo, you are a new entity. And what we tell every PhD, if you present anything, and Henry's smiling because we did this with GAPA surgery, we combined the surgical registries. If you present anything from this group, do not show your hospital slides. Show a white slide with the group logo on it. Because if you are presenting the trial results and the only thing you show is the Ottawa University slide deck, it will annoy those in the audience. So these are these very, very simple things that make a huge difference. So you're not. So I always say in the Netherlands, so we don't speak about the Dutch soccer competition. We speak about the Orange national soccer team. So think in terms of the national team rather than your city. That's
very important advice. Thank you so much, Mark. I think this is really informative. I'm really sorry to have to cut this off because we want to stay on time, sure, for everyone. I will introduce our next speaker, and thank you very much. So we have, open my notes here, Dr. Susan Tsai, who is a professor in the Division of Surgical Oncology in the Department of Surgery at the Medical College of Wisconsin, as well as the director of the Laban Pancreatic Cancer Program. She's completed medical school and residency training at the University of Michigan. She's completed a clinical research fellowship at the NCI and a surgical oncology fellowship at the Johns Hopkins Hospitals. She has a master's in clinical investigations from Johns Hopkins Bloomberg School of Public Health and she is the chief of HPB surgery at the Clement J. Zablosky VA Medical Center. Her clinical expertise is in GI oncology with a focus on pancreatic cancer. Dr. Tsai is an active in the pancreatic cancer research program and serves as the director of the Medical College of Wisconsin's Surgical Oncology Biorepository and Pancreatic Cancer Clinical Database. And her research focus is dual and includes blood-based biomarkers in pancreatic cancer and clinical trials in pancreatic cancer. Dr. Tsai, please. Thank you very much.
Thank you, Guillaume. I realize I have to shorten my bio. That's like just way too much. And I wanted to thank Sep and Guillaume for asking me to talk on this topic. I think this will be like a little bit of a rude awakening compared to what you heard from Mark. It's like the polar opposite of nationwide randomized controlled trials is investigator-initiated trials. So hopefully you'll kind of see the spectrum here. I wanted to first start by looking at the types of clinical trials, and broadly, in my institution, I sit as a disease-oriented team leader, and so we look at all the clinical trials in the portfolio, and broadly we categorize them as industry trials, cooperative group trials, or investigator-initiated trials. And the main focus of these different trials are really the objective of the trials. So industry trials are really working towards FDA regulatory submission. Cooperative group trials, as you heard from Mark, are really establishment of best practices. And investigator-initiated trials, the purpose is really to take kind of homegrown ideas from researchers and investigators who are really active either clinically or in the laboratory setting, and allow for testing of novel therapeutics, to look at devices for specific scientific investigations, specifically future funding opportunities. And just as the name implies, an investigator-initiated trial is basically the investigator is responsible for all aspects of the trial, not only sponsorship, but also conducting the trial. So why are these trials important? So at my institution, every trial gets scored in terms of a score sheet. And so you can see at our institution, the top 3 scoring trials are all investigator-initiated trials, whether they be funded through NCTN, industry, or I think institutionally funded trials. And so investigator-initiated trials really are important for developing new therapeutic strategies or treatments for patients with cancer. They are an opportunity to develop or test strategies to optimize existing therapies or repurpose those. And so IITs are very important from a cancer center perspective, as they can be actually destination trials for some patients. And importantly, they can partner with basic scientists at your institution, and that collaborative work then can be jointly submitted for potentially NIH funding. So just to give you an example of what a practice-changing IIT was, this is one example, which is the use of tamoxifen as an anti-cancer therapy. So I don't know if many of you knew this, but tamoxifen was actually initially developed as an oral contraceptive agent. But unfortunately, in the animal model, it was effective, but when it was used in humans, it actually paradoxically induced ovulation. So it was the exact opposite effect. So it was a failed contraceptive. However, it was being used by Dr. Craig Jordan, who was a researcher at Leeds, and he recognized it for its anti-tumor activity, and he convinced the pharmaceutical company, which had basically shelved this therapeutic, to do a clinical trial in breast cancer patients. So we did an IIT of 46 postmenopausal patients who received tamoxifen. 22%, a quarter of them had a response to the therapy. And then we all know now that tamoxifen is probably the leading anti-hormone therapy used in women with breast cancer. And it even led to him being recognized by the Queen of England by the Distinguished Order of St. Michael's and St. George, which is basically recognized as extraordinary non-military service. So looking at what an investigator is responsible for an IIT, so what really happens. So whether the IIT is focused on looking at novel therapeutics, diagnostics, or treatment strategies, the overall responsibilities for the principal investigator is the same, and it's kind of listed here. I'm not really going to read through this, but you can see that it's, I guess, soups to nuts, I guess is the phrase, where you really are responsible for everything from protection of human subjects, being able to be audit ready in case you are audited by the FDA, and then also be responsible for the analysis of the trial. So the good news is most institutions have a cancer center or a clinical trials office that includes certified research associates, usually a finance team and a regulatory team. So this is not something that you normally have to do all by yourself. There is a lot of support for this, but you are kind of the lead person to push everything forward. And importantly, it highlights collaboration across the institutions. So, you know, the clinical trials office will work with the Office of Grants and Contracts and pharmacy and, you know, so on and so on. So there is a lot of communication that also needs to be a little bit regulated it's so that things work efficiently. And again, that's the job of the investigator. I think investigator-initiated trials are thought to be generally faster in terms of obtaining proof of concept data. And one of those reasons is this next slide, which is probably the most important thing from my perspective from an IIT is balancing the cost. So most clinical trials, at least in the industry, at our institution, industry-sponsored trials, enrolling a single patient is about $10,000. So it's important to realize that when you think about the scope of your trial and to accommodate things according to what your potential budget might be. Now, for IITs, everything has a little bit of a different price point than for industry trials. So that's important to realize as an investigator. But of course, the endpoint of interest is extremely important. I think, Guillaume, you were talking about this before. You know, for IITs, the endpoint should be very discrete and in a short period of time, because you won't have the funds as an independent investigator to fund for survival endpoint generally. So in our experience, what we've used as endpoints is for neoadjuvant studies, the completion of neoadjuvant therapy and surgery. So it's a discrete endpoint that has a definite time. Alternatively, I've seen people use node positivity at the time of surgeries. Again, a very discrete endpoint. And then others have just been other time-based time points. But you don't want to have this trial lag for a long period of time. It's important to consider sample size, and I think, as Mark had mentioned, early stopping points for futility. That's very helpful to include in your trial design. And be very circumspect about your study calendar. I think oftentimes we want to get as much data as possible, but realize that with every data point, there is a cost. So you really want to be parsimonious in your study calendar. And then the real challenge oftentimes is the funding source, whether it be funded by industry, whether it be grant supported or philanthropically supported. One of the issues, and we've talked a little bit about this, the kind of the Achilles heels are these long time points to the long time to the endpoint of the trial, measuring a very small effect. So you really want to look for a big difference in an IIT. You don't want to be kind of looking for small hazard ratio changes. It's important to make sure that there's no competing trials at your institution. That's going to be obviously a detriment to your accrual. And then one other thought is to actually maybe not do a single site, but a multi-site IIT. And that is attractive because you could potentially double your accrual, but also know that there are oftentimes multi-site charges in terms of the regulatory oversight, which can be significant. And lastly, just avoid excessive monitoring. So for those who maybe aren't familiar with opening a clinical trial at their institution, I just provided our workflow just so that you could see there's many processes when a trial is presented first to the disease team for approval, and then it goes to our scientific review committee. After approval for there, it goes on to regulatory, so the IRB for informed consent and protocol approval. But at the same time, simultaneously, there's a budget being performed. There's a data safety monitoring committee. So there's a lot that goes on. And when you look at this with the IIT, there's a whole other step, at least at our institution, we have a whole nother step that's included where the IIT undergoes a steering committee review and a feasibility review, because IITs, I think because investigators sometimes may be new investigators. They may not be aware of all the challenges, either financial or feasibility wise, that there should be an extensive oversight for that. So the process in and of itself, I guess the take-home message is that it can take a year to launch an IIT from start to finish. So I just wanted to maybe conclude with just an example of an IIT that we started here. Again, bearing from clinical knowledge, we know that some patients are started on FOLFIRINOX and they don't respond, and you switch them to second-line gemcitabine, nab-paclitaxel, and they have a phenomenal response. So how can we kind of mitigate this time of maybe ineffective chemotherapy? So certainly there's some thought that the subtype classification of pancreas cancers can maybe predict or be associated with the treatment response. And we were lucky enough to be able to partner with another institution, University of North Carolina, Chapel Hill. Jen Janier's group has done a lot in subtyping basal versus classical, and they developed a novel assay called the Purist assay, where they could really do the RNA sequencing turnaround within 7 days, which was great. So we said, well, let's partner this new technology with a neoadjuvant strategy where patients get biopsied, and then we send their tumors to UNC for profiling, and they tell us whether it's classical versus basal subtype, and we treat them with FOLFIRINOX versus GemNab based on their subtype. And the endpoint is a 2-month response. So it's a very, very rapid trial. So this is just kind of an example of something to consider. And now I'm going to show, this is like, again, the exact opposite of what Mark said we should do. So I'm just going to show our group here and just have some summary statements. So I think IITs are a unique type of clinical trial that, you know, the clinician obviously is the sponsor and the investigator. It can address a wide variety of clinical questions, from drug development to drug repurposing to treatment sequencing or biomarker development. But it's important to be parsimonious whenever possible and avoid unnecessary costs, and be very thoughtful about your endpoints to be able to have to complete the trial. And ultimately, I think surgeons are uniquely positioned to lead IITs because we, those that are designed for operable disease, we have a unique, footprint within both the translational and basic sciences that we can fuel additional investigations.
Amazing. Thank you so much. It was really interesting. Are there any questions from the floor? I'm a bit mindful of time, so I'm going to be careful because I know our next speaker has to leave by 6 Eastern, but I think we do have time for 1 or 2 questions.
Yep, this is Shishir. Can I ask 1 or 2 questions?
Please, go ahead.
Susan, great talk as always. Thank you so much. You and Mark both alluded to pragmatic approach and be careful to how much you're asking for and being careful about how much data you want to accrue. I was wondering if you could kind of talk about your experience with the IRB, because the philosophy in this country, and this is why I think the Europeans do it so much better than us, is they have a pragmatic approach, but our IRBs and our regulatory want every minutia detail, the sodium at 3 p.m. on Monday after the chemo was done 2 weeks ago. So can you tell us a little bit about your dealings with the IRB and regulatory in terms of that pragmatic approach to what they demand? And then secondly, as you do these IITs, either single institution or multi-institution, can you talk a little bit about your plans and how you would kind of build that as a platform for larger trials to basically take your findings from these feasibility studies to therapeutic trials?
Yeah, so the first question is a great one. I think so the trials that we've done here, a lot of them have been comparison of different standards of care with variation in treatment sequencing. And so we haven't done a lot of novel therapeutics. I think it gets a little bit different when you're thinking about novel therapeutics. But in the case where you're changing standard therapies, the argument to the IRB is very simple. I think that, that these are approved agents and we have a long history using them. So that hasn't been as much of an issue. And it's also important for our cost cost containment too. We do also have kind of a registry for all of our patients that we follow people on, similar maybe like from an institutional standpoint to what is being done in the Netherlands. So that's helpful. We do capture more data than is on the trial, but we don't necessarily write that into the trial for cost issues. And then I think when you talk about maybe building networks and building collaboratives, I think that's a great point. I mean, I think that's something that our group would love to work on and expand. One of the major issues from an IIT standpoint is just the funding, because it's astronomical from at least at our institution, how much a multi-site additional regulatory costs. It's about a quarter of what it costs to run the trial. So it's not a small amount of money. So that has been like the biggest barrier, is figuring out how to cover those additional costs. But great point.
Thank you so much. I think we will unfortunately have to keep going. Let me introduce our next speaker, Dr. Schroff, who will talk about phase 2 and 3 single arm versus randomized trials. Dr. Schroff is an associate professor of medicine, chief of GI medical oncology, as well as leader of the gastrointestinal clinical research team at the University of Arizona Cancer Center. She is the director of the University of Arizona Cancer Center Clinical Trials Office, director of the Arizona Clinical Trials Network, and vice chair of clinical research in the Department of Medicine. Dr. Schroff is a clinical and translational investigator focused on developing novel therapies for pancreatic and biliary cancer. She holds multiple positions nationally due to her extensive expertise in these areas, including service as hepatobiliary subcommittee co-chair for SWOG and program committee member for GI ASCO. She's also a member of the Scientific and Medical Advisory Board for the Cholangiocarcinoma Foundation, and she has led numerous clinical trials focusing on pancreobiliary tumors, and is the national PI for SWOG 1815, which investigated triplet chemotherapy for biliary cancers. Without further ado, please have the floor. Thank you very much.
Thank you so much, and thank you all for the invitation to participate as the medical oncology component of this webinar. First of all, I just want to say this is a tremendous thing that you guys are doing, and I think it's, you know, I'm a little bit jealous that I didn't have something like this as a med onc trainee, so congratulations. So I have 12 minutes to talk about phase 2 and 3 trials, which is a very large undertaking, and so I really decided to kind of focus on what the key questions are for phase 2 and 3, because I think that helps define what the right endpoints should be. So just a quick reminder for different phases of trials and what really the questions are that are being asked. So phase 1 studies, as you know, are first in humans. So here we are not really looking at efficacy. We're doing dose finding. We're trying to understand safety and toxicity. It's usually an all-comer patient population, refractory patients that are not disease specific. Nowadays, we've gotten very creative with phase 1Bs and dose expansions, et cetera, but by and large, this is not asking a specific question of a drug in, say, pancreas cancer. We're looking for maximum tolerated dose and understanding dose limiting toxicities. It is, especially with the use of these expansion cohorts, always helpful if you start to see a signal of efficacy, but this most certainly does not answer that question. Phase 2 trials, however, are that first look at preliminary efficacy. Is this drug working in X disease? And it really takes the disease into account. So most phase 2 trials, with the exception of some disease agnostic or tumor agnostic types of trials, most of them are specific to a disease, studying drug X in HCC. And then phase 3, of course, is the confirmatory study. These are usually randomized, and almost all of them are designed hand in hand with the FDA, because they have a clear regulatory pathway for how to take this to FDA approval if that is the intention of the company or the sponsor. So phase 2 trials actually come in a lot of different flavors, and those flavors help us figure out what the right endpoints are. So when you're looking at efficacy, you're obviously looking at a larger group of patients that are being enrolled, and you want to evaluate efficacy while further evaluating safety. And you really want to make sure that what you're doing is appropriate for patients specific to a disease. More often than not nowadays, as we start to be a little bit more judicious with enrolling patients, there is of course an ethical question of, if this drug is not working, should we be putting hundreds of patients on a study. So more often than not, there are interim analyses for safety and efficacy that are built into some phase 2 and phase 3 studies. And so that's why really in the study design for phase 2 and phase 3 trials, your statistician is your best friend. I literally do not start thinking about a trial without meeting with my statistician first. So this is an old graphic actually from a CCR article, but basically defines and describes what I think is a nice way to look at and think about phase 2 studies. So you can have single arm studies or randomized studies. Even when it's randomized, I used to think randomized means you're comparing 2 arms. That's not always the case. Sometimes they are comparative arms, and the stats are built around is one arm better than the other. And sometimes they're not. Sometimes they're non-comparative, and you just have a reference arm, as we call it, which helps eliminate bias. The Simon two-stage design is a really commonly used statistical method that is integrated into phase 2 studies nowadays. It is the idea of minimizing an expected sample size when the true response is low. So like I just said, if we are putting 45 patients on a trial, let's look after 18 patients and see if there is truly some potential benefit to this combination or this drug before we enroll the additional patients up to that 45. And so this was first described in what was called an optimal design and a minimax design. But basically the idea is what is that sweet spot for enrolling enough patients to know if you've got a potential drug that you should then put more patients on. So this is a good example. I'm just going to use a number of studies that were recently done that I think really beautifully describe all of the different ways that you can think through and design trials. So this was the KNIFE trial. This was presented at ESMO in 2021 and basically looked at frontline therapy for biliary tract cancers with Naliri 5-FU leucovorin. The outcomes are not important, but basically this was a randomized study, randomized 1-to-1 to GemCis versus 5-FU Naliri. And you can see here that the primary endpoint was PFS rate at 4 months with an intention to treat. This was designed as a Simon's optimal two-stage design, but like I just mentioned, Arm A was basically thought of as a single arm study. And so it was done with a Simon two-stage. Most Simon's two-stage studies are single arm studies. And so on this arm, a certain number of patients were enrolled looking for a specific hit at the PFS rate at 4 months. The standard arm, the GemCis arm, Arm B, was really added as an internal control for selection bias because we know randomization introduces or removes the selection bias that is naturally introduced. And so the way that this was looked at is they were looking at greater than or equal to 50% of patients that are progression-free by 4 months on that specific arm. So that's just an example, I think, of a creative way that they have done a randomized phase 2 to eliminate bias, but still used a Simon two-stage to really optimize patient samples and patient enrollment within a total N of 46 that was planned. Similarly, sorry, this is a little bit blurry. Similarly, these are 2 additional studies that are randomized studies. The top study is the CheckPack study. This was a study looking in pancreas cancer patients, MET-PANC, randomized 1-to-1, looking at kind of that whole question of neoantigen generation with SBRT and IO combinations. And again, these 2 arms, this one was SBRT with Nivo alone, one was SBRT with Nivo IPI. Here, this was again a Simon two-stage because each arm was thought of separately. These were not randomized to compare to each other. They were 2 separate arms with 18 patients enrolled on each arm separately, looking for a primary endpoint of clinical benefit rate. The other reason I chose this study is because this is a perfect example of how historically Simon two-stages are done with overall response rate. But sometimes you have to take the disease into account. So this is pancreas cancer. And when you're thinking about pancreas cancer and you're looking in a refractory patient population, we all know that we're talking about response rates that are in the order of single digits, 10 to 15% tops. And so if you really want to, in a smaller study, try to really hone and understand what is happening, we know that there is a clinically meaningful benefit to disease control, almost even in addition to the response. So when you see stable disease or response, that's the clinical benefit rate. And so very commonly, you will see CBR or clinical benefit rate as an endpoint that's used in pancreas cancer studies, at least in the early stages in phase 2 studies, for instance. And so there are a number of studies that have been looked at in pancreas cancer using that endpoint. And so that was the endpoint that was chosen for this study, knowing that with immunotherapy and SBRT, the chance of response in a refractory patient population may not be great, but there could be benefit to a patient that we didn't want to miss. And so CBR was the best way to look at that. The study below is the Treetop study. The Treetop study was a study in second-line biliary tract cancers. And this was in patients who were all comers, but were randomized to receive capecitabine with varlitinib, which is an oral multi-targeting HER tyrosine kinase, versus capecitabine with placebo. And again, the reason I mentioned this study is because oftentimes the other thing that we see, especially in randomized studies, are co-primary endpoints. So as I mentioned, objective response rate is a common endpoint that is used in phase 2 studies, especially in randomized or single arm, but it doesn't always tell the whole story. And so very frequently nowadays, we will see co-primary endpoints that are chosen with statistics designed around both, around either primary endpoint being quote unquote valid. And in biliary tract cancers, again, we sometimes know that overall response rate is not always the best way to really understand the benefit of a drug because cholangiocarcinomas in particular don't respond, quote unquote, in the same way, in the traditional RECIST way. And a lot of our extrahepatic cholangios, et cetera, don't always have clearly measurable disease. And so very commonly, we will see progression-free survival chosen as an endpoint for biliary tract malignancies because that, again, is a good surrogate and it helps us really understand the true benefit or utility of a drug. So in this study, the co-primary endpoints of PFS and ORR were used. Unfortunately, the study was negative, so it did not move on to its subsequent. This was going to be a phase 2/3, but it was stopped at the phase 2. And then we have the more kind of traditional, this is kind of a traditional randomized phase 2 study. This was the NIFTY study that again looked at patients in the second line setting with biliary tract cancers who received Naliri 5-FU versus 5-FU alone. Here, this is a traditional randomization 1-to-1 where the two arms are compared against each other. So 5-FU alone versus 5-FU with Naliri and looking for superiority with the Naliri 5-FU. Here, the primary endpoint again was chosen to be PFS. For similar reasons as I mentioned. The only other thing I want to point out is that very commonly, it's an important thing to remember that PFS, if it's investigator assessed, has inherent bias in it. And so when you're designing a large study, the blinded independent central review is really an important component of both response as well as progression-free survival. And so this study had a really good, hard and fast endpoint of blinded independent central review for PFS. So for phase 2 trials, the key points: randomization eliminates bias and it eliminates issues related to historical controls. You'll see a slide in a little bit about SWOG 1815, and I will tell you that in the phase 2 that we did for gemcitabine paclitaxel in biliary cancers, the quote unquote historical control that was used as the null hypothesis, most of us know nowadays dates back to 2010 with ABC02. And we know that the median OS of biliary tract malignancies is probably not what it was in 2010. And so when you randomize, you have something to compare, and hopefully you're not looking at historical controls that perhaps are no longer clinically relevant or what we're seeing. That being said, single-arm phase 2 trials are used for accelerated approvals. As I mentioned, ORR is an endpoint in a lot of these studies versus PFS, and what disease we are treating and what line of treatment helps really kind of define that, as I mentioned, in terms of response versus progression-free survival. But for accelerated approvals, which is what the FDA has done and enabled and empowered us to use to be able to get drugs into the hands of our patients, a confirmatory study is required. And so I will say, and this is, I would say in the last 1 to 2 years, accelerated approvals are wonderful. They've gotten FGFR inhibitors to our patients in biliary cancers. They've gotten all kinds of drugs in the hands of HCC patients. But I think there are two really important questions when you're thinking about that design, and that is what happens when the study doesn't support the initial approval, when the confirmatory study makes you question what you just approved, and what happens when the confirmatory study can't get done. And so I just use these two quick examples, two drugs as an example. One is infigratinib. Infigratinib is an oral tyrosine kinase inhibitor that targets the FGFR pathway. And this is a drug that has been FDA approved based on an open label phase 2 study that looked at treatment with infigratinib in patients with FGFR2 fusion positive cholangiocarcinoma. Again, you'll note that there was a dual primary endpoint here, but objective response rate was the big one. And I'm not going into any of the details, but basically based on that study, the FDA approved infigratinib in the second line and beyond setting for patients with FGFR fusions. This is our confirmatory study. This is the study that the FDA is awaiting. This is the proof frontline trial with infigratinib, because the question is if infigratinib works better in earlier lines of therapy, do we even need GemCis? And so that's what this study is designed to ask. It's a randomization of infigratinib versus GemCis. Primary endpoint is actually progression-free survival, and secondary endpoints are listed. I will tell you that there's about 300 patients that are planned to be enrolled on this. There's also a confirmatory study for pemigatinib, and there's a confirmatory study for futibatinib. These are the 3 drugs that we have, 2 of which are FDA approved, 1 of which has a PDUFA date and should be FDA approved in the next few months. And that is a total of 900 to 1,000 patients with FGFR2 fusions that we are struggling to find. And so we've had multiple conversations with the FDA about what do we do? What do we do if we can't get these studies done? And we're trying to figure out the answers. The other issue is this, the HCC checkmate story. So checkmate 040 was a single arm Nivo study in 214 patients, and actually looked like it was a good drug. Immunotherapy could be used perhaps in lieu of maybe sorafenib. There was a response rate of 14%, and median PFS and OS was really exciting. So the FDA led to accelerated approval in September of 2017. Unfortunately, the confirmatory study was this, randomization of Nivo and sorafenib, and you'll see that the median OS was 16.4 months versus 14.7 months with a hazard ratio that crossed 1. So it was a negative study technically. And so the confirmatory study that was supposed to prove that Nivo was perhaps superior to sorafenib was negative. And so that's what led to the ODAC, the Oncology Drug Advisory Committee of the FDA, to review the FDA approval of nivolumab for HCC patients, and they voted actually 5-4 against the continued accelerated approval, and they pulled Nivo from our patients. I had patients on Nivo that I then had to justify and beg to get Nivo continued to be covered because it was actually working in our patients. So there's some tricky aspects to accelerated approvals. And then just quickly, lastly, the phase 3 trials. Usually there's a clear regulatory pathway in a phase 3 trial design. It's randomized and oftentimes compared to standard of care. The most definitive endpoint remains overall survival, but there are other surrogates, and each disease has kind of helped define what that right surrogate is, what or key secondary endpoints could be. These are typically larger studies, and I just use some of these as examples. This is an example of a study. This is the CONCO 7 trial. It was literally just presented at ASCO this year that looked at induction chemo followed by chemoradiation versus chemo alone for locally advanced panc. And what you'll see is that, and this is a very complicated schema, but basically when this study was designed, the initial plan was the primary endpoint was overall survival with 830 patients. But they hit an interim analysis. The insufficient recruitment led them to wonder, what is the question we're actually asking? Can we change the endpoint? So they changed the primary endpoint to R0 resection rate because they're asking a question of radiation. And so does that help improve R0 resection became a reasonable question to ask. And then they continued forward with the subsequent presentation and data. So oftentimes when you think about, a peri-op multimodality trial, maybe OS isn't always the best endpoint. The Clarity study is another perfect example. The Clarity study was the study looking at ivosidenib, an oral IDH inhibitor in IDH positive or IDH1 mutated cholangiocarcinoma patients. This was a study that was a double-blinded randomized study comparing ivosidenib to placebo. At the time that we designed the study, we did not have a second line or third line standard of care for cholangiocarcinoma. And so it was very reasonable to have a placebo-controlled trial, which in and of itself is complicated in the States, but we managed to do it. But again, because patients were getting placebo and we kind of had a lot of input from patient advocacy organizations, et cetera, we decided to build in crossover. So if you didn't get the IVO, you ended up on placebo and you were still eligible and you progressed, you could then cross over to ivosidenib. Well, when you have crossover, you cannot have, or you shouldn't have, OS as a primary endpoint. Why? Because that obscures your survival data, because everybody, 70% in this study, ends up getting ivosidenib. So you don't truly know what the impact is of those initial patients who are randomized. So here we had to make the primary endpoint progression-free survival. And it was actually a whole conversation with the FDA once we had the final data, because the PFS was strikingly positive, OS on intention to treat was not. And so we had to kind of educate a little bit about the relevance of PFS in this disease and why it's still a meaningful endpoint. And then this is just kind of a final slide of a classic phase 3 randomized comparing two arms. So here's the standard of care, GemCis, comparing to GemCis nab-paclitaxel with a primary endpoint of overall survival. These are more classic traditional designs, and we still see a lot of that in this day and age. So key takeaways, phase 2 trials are looking for a signal of efficacy, and the phase 3 is intended to confirm this efficacy. There are many designs for phase 2 trials, so determining the goal is going to be really important. What is the question you're asking that should drive the design and the endpoints? The FDA has been tremendous in allowing more creativity and more, novel trial design to increase the rapid access to novel therapies. This has been especially key in our, precision oncology world for biomarker-driven studies and tumor-agnostic approvals. And the age of overall survival as the only endpoint is really gone, and clinically meaningful endpoints are increasingly seen, and you just have to kind of think through, if you were treating this patient, what would be an important endpoint for you to be able to give this drug? And with that, I thank you.
Thank you so much. There are questions from the audience. Please go ahead and ask them.
I have one actually.
Go ahead.
Thank you so much. That was a fantastic review. And as always, you bring so much clarity to such a really honestly complex topic. So this was an example that you alluded to right now that, OS, and obviously like it's not like the end all be all of all endpoints for these phase 3 trials, for example. So this morning as the NCI task force, there was a lot of the new adjuvant studies, whether it's biomarker driven, like looking at circulating tumor DNA, or, sort of clinical pathologic responses, looking at tumor regression rate and stuff. And the discussion came up is like, when are we going to be ready when, sort of like to kind of accept the newer endpoints that, you clearly alluded to. And I think it's really complex because we want to stick with the science. We want to obviously be ahead. A lot of these things, by the time you're designing them, it takes like a couple of years until obviously everything is done. And by that point, you may be already a little bit behind the 8 ball. So what are your thoughts on sort of how do we go about, that difficult discussion and challenging point of like not using the old, well, it has to be, the pathologic response like to this X number, and being a little bit more creative and innovative.
Right. Yeah. I mean, I think so much of that is really dependent on, first of all, I think the FDA has been wonderful about being open to having conversations. I mean, I can say that we've had a number of kind of cholangiocarcinoma workshops with them where I don't want to say educate them, they know plenty, but, where we have a kind of a conversation and a dialogue about what is a potentially relevant endpoint in this disease in particular. And I think as much as we can at the level of the NCI and others, trying to engage them in those conversations, I think is really, really important. Those types of conversations is what led to, to what was, I think, a pivotal paper that came out. I think it was I can't remember if it was Lenny Saltz or somebody else from what was then CALGB, related to disease-free survival as a very meaningful surrogate endpoint, and not needing to look at OS in patients who undergo, this was in colon cancer and with the adjuvant world and that sort of thing. And so I think those types of conversations with both regulatory agencies as well as at the NCI level, I think of the NCI as kind of important, the cooperative group mechanism as being key to being leaders in this kind of creative space. I also think that we need to be clear on how we are validating and central reviewing surrogate endpoints, so like I said, blinded independent central review of PFS, like you need to make sure that you have some QA checks in place. If we're going to look at path response, what are the metrics, who's looking at it, where's the central path review, et cetera. I think those types of things and that infrastructure, again, within say an NCI mechanism, et cetera, needs to be built, or not built, but utilized. But I think that's probably, it's baby steps, but I think that's the way to go.
Thank you. It's a really incredible job. I think in the interest of time, if there's any other questions, I know you have to go, so I really appreciate your time. But if not, if you have any other questions later on you come up with, feel free to send your questions and I'll be more than happy to pass them on. Thank you again.
Thank you. Thanks, everyone.
And I think last but not least, we then will turn over some directions. and discussing going from endpoints to now really discussing sort of how do you decide on clinical correlatives for your clinical trials. And so our last speaker is the pleasure of introducing Dr. Tim Gretton, who is from a medical oncologist, really with the expertise in tumor immunology, running this basic science lab and doing really high-end work on CAR T-cell, IITs, phase 2, 3s, and all sorts of different with a spectrum of expertise here, really sharing with us his knowledge on clinical correlates and how do you really decide on your exploratories. So, and biomarkers. Really, without further ado, thank you so much for being here, and we're excited to hear your section.
Sorry, I think now you can hear me, correct? And see the slides. So thank you for the invitation to present. And I learned a lot preparing this. I had no idea, to be honest, who AHPBA is, etc. I also learned that actually my fellows presented at AHPBA, so I guess I should have known. But anyhow, so let's get started. And this is going to be a little different than what you heard before, because I will ask you questions, because I hate these online talks and it's so boring if we do this without anything. So this is, if you don't want to listen to anything, you can just download the talk and you should be able to see them here. And so, you know, why do we do biomarkers? And well, you know, the first thing before we go to the biomarkers is just to, you know, set the stage, and you can see these are between 2000 and 2018, the clinical trials, and the number of endpoints that we have, and also biomarkers actually are included here. And you see there's a lot that don't have any, but this proportion really hasn't changed. But the ones that actually have biomarkers as an endpoint, and you know, you just heard a lot about endpoints, has increased significantly. So that's, you know, just, you know, obviously there is a reason. And I just like to hear from somebody why you think we use biomarkers.
I'm going to point out Michael Litsky. I know I hate it. I put you on the spot. That's just because you texted me. I know he's there. Litsky, anyone in the audience who wants to just chime in? We want to make this interactive. Again, there's no right or wrong answers.
I don't know anybody, so you can say whatever you want.
I know. I'm picking. I'm going in names that I recognize.
All right, so, you know, let's not make it too complicated. So obviously, you know, we can't always go by survival, because obviously, you know, we're doing this in most cases for the patients, you know, to live a better life and, you know, to live longer. So let me get started with my talk. And, you know, the first 5 minutes or so is going to be a little boring because it's going to be about discussion, but then, you know, it becomes more interesting for you guys. So why do we use biomarkers in correlatives? Well, I told you this. So we do this because, you know, we need, we can't always go by survival. The correlatives also help us to understand the science, and sometimes, and I will tell you this, if what we do in the lab really applies to patients. So initially I will, you know, we have to go through some definitions, and I'm going to make this as easy as possible on you. And then I picked 3 different trials that I just picked randomly, which I thought actually interesting because they all have biomarkers, and you know, we can basically hopefully learn with them. So correlative science is basically a term used to show the relationship between biology and clinical outcomes. So we use this for research in patients on biospecimen. And usually, you know, we compare treated versus non-treated, or sometimes baseline versus on treatment. And, you know, let me give you a few examples for this. You know, you can see here, they can obviously be from any type of tissue, blood, etc. And, you know, we use them to define or understand who is more likely to get a disease, cancer, if you're interested in cancer, or anything else, who lives the longest. You know, it's a correlative, or, you know, we hope to identify those patients that live the longest, who benefit from a treatment, who tolerated treatment, etc. So a diagnostic biomarker is really the most important biomarker, and you use this every day in your life. And just a few examples, you know, ejection fraction, for instance, you know this, you do an echo and you get a number, and that basically tells you, you know, something, if a patient has cardiac insufficiency or not, or the HbA1c, in a patient with diabetes. So I think this is hopefully pretty straightforward. What about monitoring biomarkers? So these are biomarkers that you measure repeatedly over time, and they tell you something about the medical condition or the evidence of exposure. And here, just two random examples. You can measure quantitative hepatitis B viral DNA or HCV RNA, or you can measure a tumor marker over time. And when you take the tumor out, the CA19-9 goes down, etc. So I think it's pretty easy and pretty self-exploratory. Response biomarkers. These are biomarkers that show you a biological response. So in other words, you hope that you have done something good to the patient and nothing harmful. And examples here are a very simple one is the INR upon treatment with warfarin. Again, CA19-9, if you treat a patient, take out the tumor or treat him with the right chemotherapy. And then again, the ejection fraction is actually also a pharmacodynamic biomarker. When you, for instance, treat a patient on an ECMO and you want to evaluate cardiac function over time. And then last but not least, there is something that usually causes a lot of confusion and is not that easy to understand, especially if you compare the two. These are predictive biomarkers and prognostic biomarkers. So the predictive biomarker is used to identify an individual who is more likely than anybody else without this biomarker to experience a favorable or unfavorable effect from exposure to a medical product. So for instance, you can use as an example mutations in the BRCA gene, and you probably know that these patients are more likely to show effects to ionizing radiation or DNA, other typical different types of chemotherapy like cisplatin, leading to double-strand DNA breaks and thereby, having a different effect in the outcome. A prognostic biomarker is basically used to identify the likelihood of a clinical event. So in other words, what is the chance that this patient will go in one way and will have a better outcome versus another outcome? And this is just based on the condition, and this is not based on a specific treatment. So CRP is, for instance, one you can use this to identify patients with unstable angina or a history of myocardial infarction. And you can tell them, so this will help you to identify if they have a greater likelihood of recurrence for coronary heart disease or not. And last but not least, for this more boring part here, so the graphs. So here you can see the prognostic biomarker, and it doesn't really matter if you treat the patient. The treatment is basically the solid line versus the dotted line. You don't really see a difference in the patients that have the biomarker or that don't have the biomarker. What really matters here is that those patients that have a specific biomarker or are positive for this biomarker have a prognostic outcome here, which is better. Now, if you look at predictive biomarker, this is a typical graph here. It's now a little bit different. So if we go and look at the patient that has the positive biomarker and gets the treatment, you can see here, this is a solid black line. This is really the patient that benefits the most from this treatment, whereas the patient that doesn't get this is down here. Now, if you treat the patient that doesn't have the biomarker, and those are the ones in gray, the patient may have some benefit, but the difference is by far not as significant as the patient that has this positive biomarker. So I really apologize. This was so dry and boring. If you are interested in reading more about this, there are many web pages and sites that you can look. I got this pretty much from a biomarker working group from the FDA and the NIH. The references here on the bottom of the slide, and they will tell you way more about the different biomarkers. In general, if you go to those web pages or CTAP, etc., you will hear more. Now, I just have 3 slides about a little bit about science and what, especially if we talk about biological biomarkers and how difficult it can actually be to assess these biomarkers. So obviously, that in order to get these biomarkers, we have a tumor sample, or in many cases, you know, the non-tumor control. And you already heard a little bit about this just in the discussion before about circulating tumor DNA. Obviously, you know, we can look at the DNA level, at the RNA level, or the protein level at these markers. And then there's multiple different ways to analyze them using next generation sequence techniques. So we perform immunohistochemistry, then we will get some data. If you believe that's enough, it's by far not enough, because then you need to normalize this. You need to have the control, you need to have your standards. And then with this, you know, you can get some type of a readout, which may be a gene expression profile, or maybe PD-L1 expression, which you're probably more familiar with, or, you know, something way more complicated, such as epigenetic modification. Again, this whole process is rather cumbersome and complicated. It can be also done on biopsies, can be liquid samples that you can basically get from, you know, for different parts, depending on, you know, what your study is about. There are a number of potential issues that you can have if you don't process them correctly. You have different methods, and then, you know, here this is kind of similar to what I've shown you. And then on the last slide, the idea to potentially use liquid biopsies that was just discussed before. Obviously, in this case now, we believe that it's easier because we actually get the biopsy or the readout from a biopsy or from a sample from the blood. And this can be, in most cases, cell-free DNA or tumor-derived circulating tumor cells. Has the advantage that it's minimally invasive, may overcome tumor heterogeneity, which we have if we only get a small biopsy and may cause a problem. But, you know, obviously these are all ongoing research questions, and with a very few exceptions are not being used routinely. So now I decided, I told you I picked 3 different trials to discuss correlative and endpoints. And the first one I wanted to tell you is a disaster, because this is a study, and you probably all know the drug cetuximab, an anti-EGFR antibody that was initially approved for patients treated with colorectal cancer. And you see this is a pretty journal that you all know with a high reputation, the New England Journal. It was a large study that was published in 2004 and led to the approval of cetuximab in patients with irinotecan refractory metastatic colorectal cancer. And in this particular study, they screened patients, and they only used and included patients that were whose tumors stained positive for the EGFR. Remember, cetuximab is an antibody targeting the EGFR, so it was meant that that is probably the best population. Patients were randomized, treated, and you can see the outcome that those patients that were treated with a combination of cetuximab plus irinotecan had a better progression-free survival. Remember, these were patients that were initially actually progressing on irinotecan-based treatment. So everybody was happy, and you know, and the treatment got approved. Well, the problem is actually that, you know, over time we learned more about the EGFR signaling cascade. And yes, we can block the EGFR receptor, but the problem is that in those patients that have actually a KRAS mutation, the step from this TKI to the KRAS is basically blocked. And these patients that have a KRAS mutation will signal basically, you know, regardless of if you get an engagement of the EGF receptor or not. So in other words, it turned out, and this is a retrospective, and this is actually data from the many different trials. It turned out that this treatment is not effective in RAS mutated patients. So now, remember, initially the treatment was indicated for patients with colorectal cancer that had EGFR positive. Now it actually changed, and we only treat patients that actually have a KRAS wild type, because we knew that we learned that it's no longer effective in KRAS mutated patients. So you can see, you know, these correlatives and these markers are very helpful, but obviously, you know, you have to understand the biology behind it, because otherwise, you know, you may actually be misled. Now you think this is the end of this story. It actually is not. Now, medical oncologists talk about the side of the tumor. And right now, according, you know, to NCCN guideline, we actually use anti-EGFR only in the left-sided tumor, because we know that it actually has very limited effect as a first-line treatment in right-sided tumors. And I think, or I hope this is a good example, because colorectal cancer is a very well-known disease. I'm sure you all know the antibody that we use, the panitumumab or the cetuximab, to treat this disease. There is a biomarker initially that drove the initial study in 2004. It was the receptor, the expression. So obviously it makes only sense to use this antibody if the antigen is expressed. But it turned out that it was kind of oversimplified, and the whole story with the RAS mutation was dismissed. And the approval of this drug and the recommendation has changed significantly over time. So let's move to the next slide. And after hearing that I have to talk to surgeons, I could not resist of showing you this slide. I thought maybe you wake up. So this is a randomized trial of normothermic preservation in liver transplantation. This is a study that was actually published in Nature in 2018, and I thought it was actually very interesting. They randomized a total of 220 liver transplantations, and the idea, and I'm not going to tell you anything what they do, because I heard there's transplant surgeons in the audience, so you know this much better than me. So pardon my terminology, but the idea was to compare conventional static cold storage with the normothermic preservation method, and I guess it's a new device that they use. The study was, if I remember correctly, done in Europe. Now, I'm sorry, I have to ask you again. So now we have a primary endpoint. What would you use as a primary endpoint if you want to show, or if you really want to address this specific question? So which preservation method is better to keep, the organ alive? Anybody, any idea? What would you use as a primary endpoint?
I'm going to try one more time and pick Polanco or Jared Forrester. I'm picking names that are familiar, so I apologize if you're on the spot, but it's okay.
I'm in the OR, but I'm happy to answer. I would say liver functional blood work, or just synthetic liver function, I guess.
Yes. So basically, it's AST during the first 7 days. Okay, so you see this, it's graft injury, and yes, we know we can argue if liver function is measured by AST, but it's kind of, it's correct, because you basically want to show that the organ is intact and it's not dying. So this is if you remember that these boring definitions that I gave you in the beginning, this is a typical, endpoint that you would use here to see, viability of the organ. And this, apart from the AST, they have a number of other markers, which I thought, are maybe of interest. Obviously, biliary structures, which you are very familiar with, are a biological endpoint that we can measure using ERCP and MRCP, or for instance, median ICU stay, which was no different between the two different groups. Biliary structures were no different, and then they also found that they could actually use more organs than with the other techniques. So I thought, this is actually an interesting study, and I was hoping that this would be hopefully a little bit more related and to what you do every day. At least those are interested in liver transplant. Now we go to the third example, and I only have 3 minutes left, so I'm going to make I will maybe need 2 minutes extra. But I need to show you some science. Sorry, I just could not resist to show you some science. So this is actually work that came out of our own lab. So we used a mouse model where we have an inducible HCC using these transgenic mice. So you basically treat them with doxycycline so that you induce HCC. And you can see the experiment that we have here. These MIC mice. You start the MIC oncogene, and after 14 weeks, you can see a certain number of mice develop tumors. Now, the interesting thing is, if we treat these mice with antibiotics, these mice don't develop as many tumors anymore. They will still develop tumors, and you can see this, and they're smaller tumors, but there's a significant difference. And I think, this picture, is pretty clear, indicating that antibiotic treatment can be used to treat liver tumors. Now, I'm not a dreamer. I'm actually a medical oncologist. So I know that this doesn't necessarily work in patients. And to make a long story short, we noticed we performed immune monitoring in these mice, and I'm going to show you just one slide. We noticed that there is an accumulation of a specific immune cell subsets in these mice treated with antibiotics that was basically responsible for fewer tumor growth. And the whole mechanism is shown here. We published this 2 years ago in Science, where we basically link this whole mechanism to the gut microbiome. And the mechanism is shown here. You know that the liver is synthesizing bile acids, and basically these bile acids are metabolized by commensal bacteria. And if we treat these mice with the antibiotics, we basically kill these commensal bacteria so that these bile acids can no longer be metabolized. These bile acids actually are absorbed in the gut epithelium, go back through the portal vein into the liver, and then thereby through a chemokine-mediated mechanism lead to the accumulation of these NKT cells that I've shown you. And these NKT cells can prevent tumor growth or not. So that's a very, very brief summary of a lot of work that we have done. But remember, we also want to talk about correlative science. So so then you said, well, this is all very interesting, and you may say that MD stands for mouse doctor, but how does this actually apply to our patients? So we basically use these findings and built a clinical trial around this, and that's what I'm showing you here. Now, you have to ignore this, what I've shaded out here, because it's data from a different trial, and it's kind of irrelevant for here. So, but what we're doing here now is we basically treat patients now with oral vancomycin. So I didn't show you all this data, but basically this effect with the antibiotic could be deducted if you just use oral vancomycin. And we know that if we treat the mice with oral vancomycin, there is more NKT cells and then fewer tumors. So we decided to test this in patients, and this is an ongoing study. To make it a little bit more active, we added an anti-PD-1 antibody to the oral vancomycin. You can see here the trial design. And then the exploratory endpoints, and this is just, obviously so far it's been pretty straightforward. We only had one endpoint or so. And now you can see, you can obviously add as many exploratory endpoints. We also have clinical endpoints in this trial as you want. So we can measure immune cell populations. We can see if these immune cells produce cytokines. We can look at cytokines in the peripheral blood or anywhere else. We can measure the bile acids. We can look at the pharmacokinetics to see if these patients really took the drug that we told them to take. We talked a little bit about protein gene expression, etc. We can look at the gut microbiome. Remember, this whole mechanism actually depends on specific bacteria. Clostridium shindens is the one that we know that can metabolize the bile acids. We were worried that if you treat patients for long term with oral vancomycin, that you may actually develop VREs. And obviously, the question is, how does this correlate with clinical outcome? So with this, I'm closing, and I hope I was able to tell you a little bit about different biological endpoints and correlative science, and how we can learn from this, how we use them intelligent, how we can use them both in large phase 3 studies, in surgical studies, and then also in studies that are more translational studies based on preclinical models.
That was really fantastic. Thank you so much. What a great overview. Any questions from the audience? We were just on time, but I really want to make sure that if there's any questions, we can ask, because this is a wonderful opportunity to have access to the experts.
I have a question. Can you comment on the process by which a given biomarker goes from being something that we derive in the lab to consider sort of mainstream for clinical application? Because I'm more involved in sort of a later phases trials and large clinical trials that are more of the clinical domain. And
yes,
the difficulty I have is understanding at which point a given biomarker would be considered good enough to be considered surrogate for the hard clinical endpoints.
Okay, so there's basically two things to consider. The first thing is a biomarker that you want to use in a clinical trial as a hard endpoint is recognized by the FDA as a device. Okay, really it's a device. I know you think I'm nuts, but it's not. So basically, you first have to show them that you can measure whatever you want to do. Okay. So in other words, you know, you have to make sure that, let's say, you know, let's go back to this EGFR example, you know, that you can really get immunohistochemistry, that you have a protocol, and if this is done here, or if this is done in California or somewhere else, you know, that they all get the same result, that they all have the same protocol, that they all have the same antibody, etc. So that's the first step. Now, a lot of times, and this is not if you use it as an endpoint, but if you use it actually as a marker to include patients. So let's say, you know, again, you only want to include patients that express a certain protein, EGFR positive tumors. The FDA actually requires you to start this from the very beginning, not at the end. It's not something that comes at the end. You know, it's basically from the very beginning, you have to discuss with them and have to provide this. So let me give you an example. So we're doing a CAR T cell study, you know, where I mean, I'm sure you guys all know what the CAR T cell is. And the CAR recognizes glypican-3 on HCC. So we were required to prove to the FDA when we submitted all this paperwork that our pathologists can use the glypican-3, have a protocol, and, you know, no matter what they do, they always get the same result. That is really the main point that you have to do. And once you have that, then, you know, then nobody cares anymore, because, you know, it's like, as I said, you know, it's a device, so you can use it for anything. Then it's only the science. So if you want to use it as an endpoint, it's a different question. Then you just have to say, well, you have to prove that. So let's say this. So let's say a drop in CA19-9, a 50% drop of CA19-9 leads to a survival benefit of 2 years. You know, this is nonsense. But, you know, let's just, you know, make it easy. Then you have to say, okay, you do a clinical trial where you treat so many patients, and, you know, so many patients have a drop of CA19-9, and you show, yes, actually these patients live for 2 years, whereas the one where it doesn't drop don't live for 2 years.
So this is Shisha. Can I ask a related question real quick, as long as there's no other questions from anyone else?
Yes, go ahead. No more.
Tim, that was fantastic as always. You have such a great way of presenting the data. Related to Guillaume's question, in terms of correlative, oftentimes, you know, the correlative science that we do, particularly for cooperative group trials or IITs, they're basically exploratory endpoints. And then instead of saying the correlative is an endpoint, how much data do you need, or when do you know when you cross that threshold for a correlative biomarker that either predictive or prognostic value, where you can cross the threshold of exploratory to designing a trial basing therapeutic decisions on that correlative biomarker? So how do you know, who makes that decision of when you can cross that threshold? Because as you know, this is kind of going along with the ctDNA question right now, whether it's still an exploratory thing or whether we start doing therapeutic trials based on ctDNA.
Okay, so it's very easy. You're not there yet. I mean, we are not there yet. There's no question for circulating tumor DNA. There's like, we are so far away. But, you know, so remember the last slide that I showed you, the heading was exploratory endpoints. You know, even in this study where we do this, you know, because, you know, we don't know what the endpoint is, and we don't know, you know, how much variation you have, et cetera. So, you know, these will always be exploratory endpoints. And, you know, you just need to have much better data. And I think, you know, that's why, you know, when I was asked to give this talk and thought about, you know, how I can present this, the idea with the cetuximab that you guys all know, you know, is actually a perfect example, because we all know this. And, you know, the cetuximab story, you know, you know, is way worse. I remember cetuximab coming out, and then everybody was looking at, you know, how do you measure EGFR? And there were studies that I remember where they actually, and because, you know, you're all surgeons, so it's fun to talk about this, where they measured what day of the week the surgery was done, because the biospecimen would sit in the formalin on Fridays longer than it would sit on Mondays, because, you know, obviously there's a weekend in between, and until it gets, you know, into the right hands and the buffer is changed after 24 hours, it's different. And that actually affects the staining of the EGFR on those tumor cells. You know, so, you know, there's no gold answer. This is how much you need. You know, you just need to have solid data that, you know, that's convincing, and then you can base your study on it.
Thank you.
But circulating tumor DNA, certainly not, because, I mean, you know, we always talk about, but I don't really see any data that is convincing other than in colon. So adjuvant colorectal cancer, that's certainly a different story. You know, there we are way, you know, way advanced and have good data. And, you know, those studies where they, you know, follow this and then also, you know, decide whether to treat with adjuvant chemotherapy or not, you know, that's, you know, those are the kind of studies which, you know, are super exciting and helpful, et cetera. But I'm not aware that, you know, many other, especially the hepatobiliary tumors, you know, really are, you know, that far advanced yet.
No, I think that was exactly the question, was really around colon cancer, which is obviously the much most advanced, I think, with regards to
yes, but I mean, yes, certainly, you know, in the adjuvant setting, you know, you all know this data and have seen this. You know, it's amazing. Yes. Yeah.
Well, that's great. Well, it's we're 7 minutes past our time, so I think it just goes to show, with a lot of people still online, you know, what a really successful thing this was. So thank you so much for all this, to all the speakers that were here, and obviously everyone who logged in. If you have any questions, please go ahead. If you have any feedback, I think we would love to know. As you know, this is our first time doing this, so we are all learning with you, and we would appreciate any feedback to us. We will send out the questions to the webinar in the next week or so. And as long as you do the questions and listen to all these sessions, you will get your certificate. So please don't forget. And with that, we will close the session. And thank you, Guillaume, to helping me moderate this.
Thank you all.
Bye.
Thanks, everyone.
Thank you.